Good evening, everyone. My name is Marco Rizzo, and on behalf of myself and co-chair Dr. Chuck Cassidy and AO North America, I'd like to welcome you to the first session of our 2021 AO North America Advanced Risk Summit. This will be a weekly series of sessions, topic-based, ranging from fractures to reconstructions and arthroscopy, focusing primarily on the wrist. And tonight's inaugural first session will be on distal radius fractures, a condition which is very common. We have a tremendous program over the next several weeks up until April 8th. And I've never seen a program with such outstanding faculty, and we're blessed to have world-class faculty, doctors like Dr. Jesse Jupiter, Dr. Peter Stern, Dr. Lee Osterman, Dr. Doug Hanel, Thomas Fisher, Dr. Gupta, Dr. Geisler, Dr. Axelrod, and many, many more that I feel privileged to have learned from and blessed to continue to learn from. So we hope that you'll find it as enriching as I know it'll be for me. And again, without further ado, I'd like to introduce Dr. Axelrod, who will be moderating this session. I will add one last comment from a logistical perspective. The third Thursday of every month will not have, due to a conflict with an ASSH event, we will skip the third Thursday of every month for the sessions. So Terry, thank you for allowing me an introduction.
My pleasure. Thank you very much for everybody for inviting me and giving me the honor of doing the lead off on the first session. So as Marco said, this is the first session of the AO Trauma Hand Group North America Online Series. This is the Advanced Risk Summit, and the first session that we're going to do for this week is on distal radius fractures. We're blessed to have some pretty impressive faculty, Chai Mugdal from Harvard Medical School, and Willette from Baptist Health, South Florida, formerly of Miami, and Jeff Lawton from the University of Michigan, who's sitting in his fancy race car seat today for us. These are the disclosures that we have to go through, but before I do that, the idea of this session is to highlight some very specific aspects of distal radius fractures, not to go over distal radiuses from top to bottom, but to pick 3 or 4 critical issues in the management of these injuries that sort of face us on a day-to-day basis. So I'll give you more about that in just a second. So these are the disclosures, and you're free to look at those at any time, but we've vetted these with the ethics committee, and everybody is good to go. Everybody's microphones will be muted, so you don't have to mute your own, because we've kind of taken care of that from our support staff at AO North America. But we're going to be keeping the Q&A box open throughout the session, and I really encourage everybody to type your questions in. Some questions we're going to just answer directly in the chat box. Other ones we'll try to do our best to answer live, depending upon the amount of time that we have available. So the learning objectives for our session today is to, there's 4 of them really. One is to be able to discuss the rationale for surgical versus non-surgical management of distal radius fractures in the low demand sedentary population. And we felt that this was a good topic to touch on because there's been this boom in internal fixation of distal radius fractures. And those of us that have been around the block a few times, like Dr. Jupiter and myself and Dr. Hastings, know that lots of these senior patients really don't need surgery, and they can do fine with closed treatments of their fractures. So we're going to touch on some of those issues that might lead you to surgical versus non-surgical in a lower demand older person. The second is this pesky little volar lunate fracture fragment, and how we have to be very careful to stabilize that when performing an RIF, because it plays a pretty critical role in the management of distal radius fractures. The third talk is going to be understanding the limits of volar plating, because not all fractures of the distal radius can be managed with a volar plate. Even if it locks, it's not going to fix everything. And then there's this final talk, which I'll sum up at the very end, which is what to do with the difficult fracture, the one where the fracture fragments are just too small for fixation, or you're rushed, or the patient's unstable, and you need something just to do in a quick fix for the situation, or it just looks like it's non-reconstructible. This is the spreadsheet of how we're going to do it, and Jeff Lawton's going to lead off in just a minute with operative versus non-operative. Chai is going to talk to us about that small volar ulnar fragment, and is going to talk to us about volar fixation, not applicable to all distal radius fractures, and then I'll finish off with what to do when the fragments are just too small to fix. So we're going to lead off with the case. So I'll ask you guys who are on board with us today to keep this case in mind, because we'll finish off with it at the end of the session. This is a 63-year-old woman who had a fall on the ice and injured her dominant right wrist. We'll hear that scenario quite commonly. But what's different about this person is that she has inflammatory arthropathy. It's not necessarily rheumatoid, it's more of a seronegative arthropathy. And she's on prednisone and has been on prednisone for about 30 years. She's also been on methotrexate for about 15 years. She has some sort of cardiomyopathy and has been told by her cardiologist that if she has a general anesthetic, if she has an anesthetic, she'll die. And so she's made it very clear that she doesn't want surgery because she doesn't want to die. Seems a bit different, but that's the story that she told me. So these are the initial injury films. Not too bad, run-of-the-mill distal radius fracture, a little intra-articular split here, not too badly displaced, and then it's reduced. And that's how it looks. So I just want you to keep in mind this case, because we're going to come back to it at the end. So at this point, I am going to pass the podium on to Jeff Lawton, and he's going to talk to us about surgical versus non-surgical management of the distal radius fractures.
Excellent. Thanks, Terry. So again, how do we decide on operative versus non-operative management of distal radius fractures in the low demand patient? I would like to thank and acknowledge some help in cases from Terry Axelrod, Marco, John Capo, and some information from Peter Ree. So our objectives are to increase our comfort in the diagnosis and evaluation of all patients following distal radius fracture. Again, so my talk is going to center on non-operative management, but I think it's important to be able to offer a patient both appropriately. Understand the importance and demands and expectations that a patient might have and not just focus on their x-rays. Understand the role for surgical management and, as a result, non-surgical management options for distal radius fractures. And again, we'll talk about older patients versus lower demand patients. So I trained in the early to mid 90s, so sort of not so long ago, but it seems like a long time ago. And really, we considered anyone over 65 as, don't worry about it. If it was their non-dominant hand, we put less emphasis on that. And that was our sort of framework at that point. We didn't have, or at least we weren't smart enough to know about 85-year-olds running marathons and people later in life being very, very active. A number of my mentors from my 15 or so years with the AO, not knowing specifically their age, but they're probably there, but very active. Peter's very active, Tom Fisher's very active. Hill and Jesse are joining us from their ski chalets out west. So age isn't the important thing, it's the patient's activity level and their demands. So I want you to think of lower demand patients as patients who are maybe medically low demand, older people that want to play cards or sit on the couch and hit the remote, or maybe do some light gardening, but not tilling the soil, etc. So that's what we're really talking about, are these sort of lower demand patients. So our working hypothesis is that this X-ray, which most of us would say, if we operated on this, we would call that a malunion. That can be associated with someone who's perfectly happy with their range of motion and their function, and they're able to do what they need to do despite how the X-rays look. So again, we want to think about our indications for operative treatment, and I'll talk about those briefly, but really, what is the role for non-operative management in some of our lower demand patients? So any person that you see, whether they're 82 or 28, you want to think about the fracture, the fragments, all these different fragments that we talk about. And then we have some criteria for treating distal radius fractures, but again, we want to remember to treat the patient and not the x-ray, and not be honed in on a specific number. It is important to know if someone has a fracture, who's likely to be stable and who's likely to be unstable, because you have to anticipate, and LaFontaine gave us some great criteria to anticipate who's going to maintain a reduction and who's not going to maintain a reduction in terms of dorsal comminution and age. So again, that's not the purpose of this talk, but we need to be aware of those things. So there was a nice review on distal radius fractures in the elderly in the Journal of the American Academy of Orthopedic Surgeons. And as we all know, these are common, and our goal is to provide a painless extremity with a good function, realizing that most of these are treated non-surgically. While surgical treatment can improve alignment, it's really not associated with clinical outcomes. So this is just a couple of their teaching points from this review article. Initially, after reduction, placing the patient in a well-molded splint or cast. Notice there is a little bit of wrist flexion here. We'll talk about avoiding extremes of hyperflexion, or the dreaded cotton loader position. And again, you see a well-molded splint with a little bit of wrist flexion, and certainly an acceptable alignment. This is another patient that they chose to show that despite their dorsal angulation and loss of radial length, at healing did well and was happy with their result. So Kevin Chung, my colleague at Michigan, has written a lot about operative and non-operative management in older patients with distal radius fractures, and the opinion of this particular paper was that patients especially older patients, like a shared approach to decision making, not being told have surgery, don't have surgery, but to participate in that decision making. So I think it's important to inform patients what to expect from both operative and non-operative management, and get their involvement in that decision making. So here's a typical patient, 82-year-old woman, fall under right upper extremity. This case is from Marco. This patient underwent a closed reduction, and one of the sort of little key things to look at in these pictures from fluoro is the distraction. So right away you can tell this is a fluoroscopy picture of a patient in traction, because you see that radiocarpal distraction. Just a word, you see the outline, the radiographic outline of these metal finger traps that many people are familiar with. Just realize that these are pretty abrasive and can be pretty brutal, especially on older patients with relatively more frail skin. So putting a 1/4 inch piece of tape around the finger, if you're going to use finger traps like this. I like these synthetic plastic finger traps. They can still cause skin problems, but far less aggressive than these metal ones. A well done mold. Notice this patient, unfortunately there's finger troughs there. That's to be avoided. But despite those little finger troughs, a nice mold, a nice reduction. And then part of the importance of having a patient with an unstable fracture that we've reduced is you have to be inclined to be able to follow them more frequently. So here it is at a week, here it is at 2 weeks, and now we'll flash forward to 2 months. So this patient has maintained their reduction. And then right out of the cast, as you can imagine, at 2 months, she's a little bit stiff, but she's happy and satisfied with her decision to pursue non-operative management. This is a patient of mine, 72-year-old lady who is very active. She still runs her piano instruction school for elementary school kids, but not very high intensity activities with her hands. And she chose non-operative management. And at 2 months, she's got this x-ray, and you look at that and you say, oh, she's lost radial length, she's lost radial inclination, she's lost her palmar tilt. And you can go through all these machinations of, well, does she have ulnar carpal abutment? Should we think about a distal ulnar resection? Should we think about an ulnar shortening osteotomy? Should we think about a radial osteotomy? And really, she wants none of that. She's back to teaching her kids, but she does say, can you help me with this numbness and tingling that's driving me nuts at night? So, think about carpal tunnel, and it turns out that's all she needed. She was perfectly happy with her malunion and back to her level of function. This is another patient of mine, 72-year-old lady who had a ground level fall and for a number of reasons elected conservative management. And again, based on LaFontaine's criteria, we do see some dorsal comminution, and we're a little worried about that. But she's well aligned. So at 2 weeks, we see her and she's tipped back a little bit, talked with her about it. She still wanted to treat this non-operatively. And I had her set up to see her in 2 or 3 weeks, but she called miserable a week later, now with numbness in her index and thumb. And as you can see, she's lost further angulation. So at this point, an option to do a carpal tunnel release, she actually opted to do basically an osteotomy, takedown of her nascent malunion, which again, we have to follow people closely. And you can see not perfect, but she's happy with her results. And again, so we sort of switched gears and went from non-operative management to reduction with internal fixation and released her carpal tunnel. This is, again, a 66-year-old woman who had a fall, and you can see at time 0, at a week, you can see she's getting some dorsal inclination. At a few weeks, she's got more dorsal inclination. At 6 weeks, again, she's comfortable, she's happy with things. And then I'll give credit to Marco, because at 6 months, he saw her back. And again, radiographically, she's got 20 degrees of dorsal inclination, lost some radial length, but from a functional standpoint, she's doing great. She's happy with her decision. Maintain great form rotation and great function. So again, a couple things to avoid. I sort of brought this up earlier. This fella in the suspenders came to see me. He loved his neon camouflage cast put on at another office, but wanted some help with his stiff fingers and his carpal tunnel syndrome. His fracture was fine, but the sequelae of this position, despite the assertion by Dr. Cotton in the early 1900s, we want to avoid extreme wrist flexion. That takes its toll on the fingers, so you get stiff, swollen fingers, and increases the chances of a carpal tunnel syndrome. So a little bit of wrist flexion is okay. Neutral is maybe better, but certainly want to avoid extreme positions to maintain. So some take-home messages. We want to think about treating the patient, not the X-ray. A bad-looking radiograph doesn't necessarily result in poor function. And in many patients, especially in this sort of group we're talking about, we're not really worried about post-traumatic arthritis in 15 years, because again, their activity level at this point is not high, and 15 years from now, it's going to be even less. And again, if they're unhappy, some patients do need something. A distal ulnar resection is a very predictable procedure. Again, carpal tunnel release, not uncommonly, or even a radial osteotomy. These are some of the references that'll be included in the download. Thanks.
Thanks, Jeff. That was great. I just have a quick question. You emphasized the critical importance of involving the patient in the decision-making process. Do you want to expand on that a little bit? Because that's certainly been my experience as well. People don't like being told what to do.
Absolutely. And I tell patients, if they show up and they have, loss of radial length or loss of dorsal inclination, or if I say, we're going to start treating this non-operatively, and then you have to think about, sort of a criteria or a threshold. So if you lose further radial length, if you begin to have ulnar carpal abutment, we can always talk about taking down a nascent malunion. And it's important to understand first as the surgeon, and then to explain it to your patients, that the X-ray doesn't have to look perfect for you to have a decent result. It depends if it's an 80-year-old that plays tennis 3 days a week, or an 80-year-old that wants to play pinochle 3 days a week. So really letting the patient be involved in that decision, and telling them what you have to educate them on what to expect, but then they have to be involved in the decision.
Absolutely agree with that. Okay, that was great. If there's any questions, there were a couple that came up in the Q&A box that we've addressed already. One of them was about when you're doing a closed reduction, when you're trying to train your residents, how much of the cast padding? I mean, Marco and I have kind of answered that, but in your own sense, like how much do you tell them to pad the splint before when they're doing the reduction?
Yeah, so excellent question. And we usually, want 2 layers at those points. But the more important thing, as I tried to highlight in those pictures, and we've all done it, you want to make sure you're using the palms of your hands to do a gentle mold as opposed to, getting your fingers in there. And that's the most important thing, is to do no harm. Being careful, realizing the skin is fragile in terms of the finger traps, in terms of if you're doing a hematoma block, things like that.
Yeah, more than one patient in my experience when I was training as a resident did end up with a skin slough just from overly putting too much pressure on it or sliding as you're pulling it distally. So you do have to be very careful about that. Marco, did you have a point about that?
No, yes, Dr. Hill Hastings had a wonderful point, and I'd like to bring it up for discussion. What do you think about positioning the wrist in mild extension following reduction? Placing the radiocarpal forces palmarly rather than dorsally. As always, Hill has such a wonderful perspective on things. I'd love to hear your thoughts.
Yeah, Marco, I agree that review article from the Academy Journal talked about flexion. I quite honestly recommend just neutral. In other words, if you have to do flexion to keep the reduction, in my mind, it's not worth the flexion. But if you could do extension, if you all try in your own hand, our fingers just work better with a little bit of extension. Certainly not in flexion, and neutral to a touch of extension is better for the fingers.
Thanks, Hill, for sharing.
Jeff, there is one more question from our participants, and that is, what do you think of the role of re-reduction? Say you follow a patient weekly and it redisplaces at a week or two. Is there any role for re-reduction without surgery?
Yeah, so I mean, I guess I look at the original X-rays, the original reduction, and based on LaFontaine's criteria and others, Tornetta's had some things about how stable do you expect, and if I don't expect the fracture to be stable, I don't want to put the patient through a re-reduction because they're sitting in my office, so I can't give them any sedation or any kind of pain relief. I haven't had good luck with a hematoma block a week plus out. So, it's an uncomfortable thing for the patient, and I don't think there's much to be gained from it in an older adult. Now, that's very different. I see a lot of teenagers, tweenagers, 11, 12, 13-year-olds, and, big metaphyseal fracture that's going to be inherently stable, and maybe they just suffered from a poorly applied splint, or maybe they took off their own splint. I think that has a chance of succeeding. And if sort of mom and dad are on board, that I think I would encourage re-reduction. But if there's a lot of dorsal comminution and it wasn't going to stay in the first place, I don't put the patient through a re-reduction. We decide to either accept it or we do something else.
Jeff, I think that's a great comment, and I would just tell our participants that this is an opportunity for you to interact with this esteemed faculty. We have a great group that we have for this next series of lectures, and you have the opportunity to get inside their heads. Just ask the questions that you want to ask relevant to the topic. So please feel free to input into the chat box, and we will ask your questions.
Yeah, that we tried to organize, or I organized the program for tonight to allow lots of time for back and forth discussion like this. I just going to emphasize what Jeff said in response to the question of re-reduction. My approach is very similar to yours, Jeff. It's just if it's going to require a general anesthetic, to me, the worst thing to do is to give a patient a general anesthetic or a regional anesthetic in the operating room, do a closed reduction, and then have it fall off again. So if you're going to go to all the trouble and the patient's going to go to the trouble of going to the OR, I'm not going to take a chance of it falling off again. So I'm just going to go ahead and fix it. I mean, to me, if it's good enough to require another reduction, it's good enough to fix. So whether that fixation is a volar locking plate or percutaneous pins, we can get into a discussion about that. But that's sort of the way I look at it, because I don't want to have to come back with my head in my hands and say, guess what? It fell off again. You got to go back and do something else. So, yeah. So there's another question about is the potential for CRPS, complex regional pain syndrome, a real consideration of ours in deciding surgical versus non-surgical approaches in the management, or is it something out of our hands as a result of the sequelae of the injury? So what do you think about that, Jeff? Do you, when you have somebody that's, you know, do you think CRPS plays a role in your decision-making about operative versus non-operative?
I don't, because I unfortunately have seen patients that have had a regional pain syndrome from both non-operative management and operative management. You know, certainly with what we do have to worry more about iatrogenic pain, swelling, and stiffness. Whether or not each of those cases is really CRPS or just a patient that's having pain, that has some swelling post-operatively and has some digital stiffness. You know, you can sort of make an argument, but certainly just the injury, the distal radius fracture, puts someone at risk of a complex regional pain syndrome, leaving it displaced, leaving potentially increased traction on their median nerve from a mal-reduced fracture. I mean, I think reduce it, and yes, they may have a risk, but that wouldn't enter in my decision making about fixing it or not fixing it.
Just highlighted your point there. I'm sorry to interrupt you.
No, go ahead, Marco.
He highlighted your point there, Jeff, about the median nerve. Most cases of CRPS are related to the median nerve. So having a good heightened awareness of that is helpful.
Yeah, if I can convince myself that, when it doesn't take much convincing, that their acute pain syndrome is associated with compression of the median nerve, that's going to push me, quite surprisingly, to doing surgery, as opposed to the old idea, never touch these people, because then I'm going to take them to the OR, do a carpal tunnel release, and fix their fracture. And Jesse, I'll thank extensively for teaching me this, and it's really made a big difference, because a lot of times, if they've got features of pain syndrome that can be attributed to median nerve compression, they're going to get better real quick if you do the release. So that's a very good question. So thank you for that, Siobhan. And then there was another one about asking about how long do we keep a patient in a cast? We're just kind of, I'm an orthopod, so I do the typical one orthopedic unit, which is 6 weeks. And then if I take their cast off at 6 weeks and they're still a bit tender at the fracture site, I might put them back in for another 2 weeks, but that's about it. I would never go more than 8 weeks in the cast. Jeff, anything different than that?
That's exactly what I do.
Yeah.
And then a removable splint for comfort, and then back to activities as their comfort allows. Yeah, exactly the same.
Very good. Okay, so I know we've got time for a couple more. There was one question about counseling patients on what they can expect functionally with non-operative management if the fracture is short and angulated, so that they can make a well-informed decision.
Yeah, so again, depending, so some of those that I showed, if they've got 30 degrees of dorsal inclination, you can anticipate for those patients that they're going to lose some palmar flexion. Yes, they're going to gain some dorsiflexion, but overall, compared to their other side, they're probably still going to lose some. But again, they're going to have a functional range of motion and the ability to load the wrist and do their activities. I see a question from Doug Hannell about vitamin C. He asked if anyone discussed that. If a patient brings it up, I certainly talk with a patient about that. Since the evidence has sort of gone both ways, I haven't brought it up recently because the evidence sort of leads us in both directions. So, Terry, what do you counsel, or do you counsel patients on vitamin C?
I with the new evidence coming out that it's not necessarily any help, I must admit I don't push it. But if they have some early features of it, I do tell them to take it, but I certainly don't advise it for everybody. I know it's kind of a no-brainer to do it, but I must admit that I just don't. I don't know. Okay. I think that we should move on. So Jeff, that was great. And thanks for everybody in the audience. So keep the questions coming. We'll probably get to almost 90% of them as we go through. And so I'm going to pass the podium on to Dr. Mugdal from Harvard, who's going to talk to us about what do we do with that small pesky volar ulnar fragment.
Thanks, Terry. So my charge is to talk about the volar lunate facet fragment, and the goals for this are basically want to try and understand the unique anatomy of this lunate facet with the help of radiographic evaluation and fracture pattern assessment, and then decide which surgical approach suits our particular case and evaluate various fixation strategies. And we'll do this with the help of 5 cases, each of which has an attached reference which highlights what I'm talking about, and each of which will have 1 or 2 important points. Now, if we think that we've gotten really cognizant of this problem in the last 15 or 20 years, think again, because Terry Axelrod wrote about this particular problem nearly 32 years ago. So what is so unique about the lunate facet? Well, it is not located at a level that you would want it to be to fix it with a volar monoblock plate, in that it extends volarly, distally, and ulnarly. And as shown in this picture from Amit Gupta's dissections, it bears the attachment of the radiolunate ligament, which goes all around the equator, if you want to call it that, as seen highlighted by this purple circle. Therefore, if you were to not pay attention to it, and you think that the fracture is represented by this purple line, then think about it. Right attached to that fragment is your short radiolunate ligament. And if this fragment were to displace, as shown by this blue arrow, then not only does the fragment go that way, but it takes the entire carpus with it due to the attachment of the short radiolunate ligament. So therefore, before we start treating this, we should recognize it. And how do we recognize it? Well, in non-CT available situations, the best way to do is what Rob Medoff told us, is to measure the teardrop angle. The teardrop angle is basically a surrogate for the volar inclination of the volar lunate facet. And normally it is about 65 to 70 degrees and is measured as shown in this diagram here. If the teardrop angle increases, it usually represents a volar marginal shear, either an isolated volar lunate facet fragment or a volar Barton fragment. Conversely, if it reduces, it usually represents central impaction. Now, plain radiographs are good, but if a CT scan is available, I'm going to go out on a limb here, then a CT scan must be done so that you can assess the fragment geometry carefully, because only then can you analyze the fragment and the fracture patterns. Over the last 30 years, in my assessment, the fracture patterns usually follow these 3 patterns almost reproducibly and consistently. The first pattern is what I call the boomerang pattern, which is seen on the left side, and it is usually seen in isolated fractures or in volar Barton fractures, as shown here. The second pattern is what I call the sliver, which is commonly seen in radiocarpal fracture dislocations. And finally, the third pattern is the column, which is seen in isolated fractures as well as in complex distal radius fractures. I won't belabor the point by reading this, but I'm going to leave this for about 5 to 7 seconds. These are the tools I keep handy in my operating room whenever I'm dealing with fracture of the distal radius where I'm concerned that a lunate facet fragment may be present. So let's start off with case number 1. Now, when you're dealing with an isolated lunate facet fracture, you have to have adequate knowledge of the various tools of the trade that you have to have available. This paper highlights those tools. So here's a 62-year-old female registered nurse who fell from standing height. And you can see from the x-rays on the left that she already has pre-existing radiocarpal arthrosis. Her teardrop angle, as seen from the x-ray in the middle, is clearly increased, and a CT scan shows that the entire volar lunate facet has come off. So these fractures, when they're isolated in this fashion, I usually approach with this extensile approach, the extensile carpal tunnel approach, and I take the plane between the median nerve and flexus on the radial side, and the ulnar neurovascular bundle on the ulnar side. Now here's a tip. If you flex the wrist and put a large bump behind it, retracting the median nerve is much less tortuous to the median nerve itself, which is shown here by the red arrow. How do you identify the fragment? Because when you elevate the pronator quadratus, you can barely see anything. So I usually run a freer along the ulnar aspect of the distal radial shaft until I feel that uneven step of the radial cortical defect. I then exploit that defect, elevate the fragment, and push it distally. And it leaves me with this boomerang-shaped defect, which I then graft, and I fix it with a headed screw, which is cannulated, put a guide wire in, and you can see that it looks pretty good. I then push the guide wire out the other side so I can grasp it with a forceps or a snap so that it doesn't come out when I'm drilling. And then it's just a matter of putting a screw in over it. I use a screw with a washer because it behaves like a one-hole plate. Is that adequate? In some circumstances it is, but this lady had come to me a little later and she had to be grafted, as you can see from these pictures here. I had to use graft once I elevated her back. And I therefore felt that the stresses on that one screw would be too much for it to bear. Therefore, I used a buttress plate along with the screw and gave an additional layer of security. And here she's at 9-year follow-up, doing reasonably well with no pain. Case 2 highlights the fact that we have to go away from the concept that volar Barton fractures are single fragmentary. They are multi-fragmentary in my book, unless proven otherwise, and this paper highlights that concept. So here we are, a 30-year-old male who came off a motorcycle at very high speed, and as you can see, he's got a volar marginal shearing fracture, if you want to call it a Barton's. And as you can see from the CT scans, the red arrow and the yellow arrow are pointing to the lunate facet, and you can clearly see that this is multi-fragmentary. So the teaching I do with my residents is a volar Barton fracture, unless proven otherwise, will always have a separate lunate facet fragment, which you have to be on the lookout for. Now, in the days that I fixed this, I was ready to fix it with a standard FCR approach, and that's what I tried to do, quickly realizing that my access to the lunate facet fragment was inadequate. So point number 2 for this particular case is that you don't have to panic, don't have to make a separate incision, merely take your dissection subcutaneously all the way across to the median nerve, and then you retract it so you can approach the lunate facet fragment from the ulnar side. Why do I need to do this? Because the trajectory of fixing this with a screw requires an angulation of your hand so much that you can't do it from the FCR approach, and you have to bring your approach over to the ulnar side. And then I fixed the fragment with the screw and added my monoblock plate to fix the rest of the fracture. And here he is at about 6 months. This case highlights how to manage radiocarpal fracture dislocations, which usually consist of very, very small fragments. Here's someone who was involved in an MVA. And if you look at these x-rays, you don't get a sense that the lunate facet is involved at all until you get a CT scan, thereby highlighting my point that getting a CT scan is critical in these fractures, if at all possible. So you look at these fragments and you can see a dorsal radial fragment, you can see a radial styloid fragment, as well as a lunate facet fragment. Now we know that this fracture geometry is predictable and consistent in radiocarpal fracture dislocations type 2. So when you have these small fragments, you cannot really fix them with a plate. And therefore I say small fragments means small devices. So I chose to fix each fragment on its merits with a screw, either cannulated or not. And I fixed the lunate facet fragment with a suture anchor. So that's another trick to remember. And here she is at about 1 year. How about a delayed diagnosis? This paper highlights the features of delayed diagnosis and how to approach decision-making when taking care of a delayed diagnosis. Here's a male who underwent multiple debridements for PVNS affecting his wrist. And the surgeon who took care of him had done all of these debridements with using an extensile carpal tunnel release approach. So I had no choice but to utilize that. He was told that he had a wrist sprain until he came to see me at 3.5 weeks because his wrist was still hurting, and that's what he looked like. Now you look at his CT scan and you realize that he has a sliver pattern of avulsion or a displacement of his lunate facet, but this sliver actually extends halfway across into the scaphoid fossa. So for me, this was too large to be fixed either with an L plate or with a screw. And besides, he had come to me almost 3.5 weeks down the line. So I chose to do something a little different. The yellow arrow points to his PVNS spouting out through the volar wrist capsule. I chose to use a T plate. And if the surgical trick to remember here is that if you use a 2.4 millimeter T plate, then a 3.0 millimeter cannulated headed screw actually fits through this plate. So I chose to put the guide wire through the plate, buttressed it before, and then fixed it. As you can see, grabbed the fragment, guide wire is coming out the dorsal side, and put my cannulated screw over it to add an additional layer of security because this was an older fracture. And here he is at about 1.5 years, doing reasonably well. His radius scaphoid articulation is arthritic, but it was before he came to see me. Finally, an intraoperative diagnosis needs to be addressed, especially in the older person who is osteoporotic and whose requirements for fixation may be entirely different from those of a younger person. Here's a lady who fell out of an olive tree, and when she comes to see me, you can see that her teardrop angle is actually reduced, thereby suggesting some degree of central impaction. So I was reasonably confident that I could address this with a volar monoblock plate and went about doing that. But here's the lesson I learned, that intraoperatively, you must always look at the lunate facet because there was something not quite right as shown by these red arrows. You can see a separate shadow, and that was the displaced volar lunate facet. So this was a relatively easy fix. I used a one-hole plate with a cannulated screw with a washer and restoring that important fragment. And there she is at about 1 year. So these are the common fixation techniques, but can you use alternative techniques? Now, whenever you're dealing with these injuries, you have to always be prepared to look next door. What do I mean by that? Here is a case which was reduced of a radiocarpal fracture dislocation, and you can see that the post-reduction x-rays actually highlight a concomitant scaphoid fracture. So whenever you see these injuries, especially if you're going to get a CT, always scan the entire CT to look for carpal injuries. So in this case, you look at this fragment, it is quite small. And I was quite confident that I would not be able to fix it with traditional fixation techniques. So I chose to do what Jesse had described many years ago. I used a wire suture and I passed it around a 2.7 millimeter screw, which I used as a post, something that I learned from our sports medicine colleagues. So that's a wire suture, which pulled it right back into place, giving it an excellent restoration of the volar lunate facet. So what are the take-home messages? The volar lunate facet extends distally, volarly, and ulnarly. You have to maintain a very high index of suspicion at all times to look for it and be prepared to fix it. The fracture geometry, in my opinion, is largely predictable, and small fragments require small implants. So I'm going to stop there, but the last two slides will help learners get some references that I'm talking about, and they are provided here for your future reference. Thanks very much.
Shai, it's Terry here. Would you mind going back to the fourth case, just so I can ask you a question about that?
Hang on, let me go back here. Fourth case, okay.
So that was the delayed presentation. The one before this. That one.
Yeah.
Okay. So do you have, I find this to be the most challenging of the distal radius fractures to deal with. That is the delayed presentation,
Yeah.
where the lunate has gone with the lunate facet fragment, which is perfectly illustrated on that x-ray on the right. And even though I take it all down, so I'm talking about the delayed presentation here,
Yeah.
not the acute, and which is exactly what you have in front of you, the delayed one. I've had trouble keeping the lunate reduced. And if you, your initial x-rays look great, but then it looks like your follow-up, he progressed to a little bit more volar subluxation again, perhaps eroding against that fragment. Do you ever do anything supplemental to hold the lunate where it should be, in addition to putting the fragment back? So do you K-wire the lunate to the distal radius, like a transarticular K-wire? Do you put an X-fix on? Do you do a Hano plate? Do you ever do anything else to help?
So in the interest of time, I did not add his X-ray from 5 years prior to this, which actually showed that his post-operative reduction was exactly where he normally sat.
Oh, okay.
And what I had actually here was flattering.
Yes.
I don't think it was real, it was apparent. I just patted myself on the back too early. And then I went back and looked at his X-rays from before. And he used to be sitting here all the time. But regardless, if for any reason I don't get it back where I think it should be, then I prefer putting a dorsal plate on or using an external fixator with a distractor, you know, the small distractor that we use for distal radius osteotomies.
Yes.
I can use that. And you might need to use a pin or two in the base of the third metacarpal, as well as in the body of the capitate, to literally bring the carpus back in line with the radial platform. And I can either use that, or I don't use the handle plate necessarily, but I use the straight plate from the wrist fusion set, because that I find that a lot more useful, and I use that all the time. So I use that plate instead.
So those are a couple of things that can be helpful
Yeah.
when you're not 100% convinced that fixing the little fragment will hold up.
Yeah.
And I don't find that to be necessary with most acute ones,
No.
as I'm sure you don't, but it's the delayed ones that are 3, 4, 5 weeks out or longer,
Yeah.
where I think you have to have them as a backup if you need it. So just for people that are listening in, just think about that if you do need to throw something else into the toolbox.
And frankly, if you look at this picture where you see the amount of PVNS spouting out of his corpus, I was surprised that he has this kind of motion.
Yeah.
But the patient was he was actually delighted with his outcome and told me that this is exactly what he's had before. So I'm going to take that as a win.
Absolutely. That's a great case. So thank you very much. Are there any questions? Our participants, we've answered a lot of the questions as we've gone. I'm just going to bring up one question related to the one comment made by one of our hand therapists who talked about the use of graded motor imagery program for patients that have acute CRPS. And they were using it for both surgical and non-surgical patients and having good success with it. So all of us are looking for a magic bullet for our patients with CRPS, because they're definitely not much fun to look after. They're difficult to manage. So anything that might help, we're going to be happy to look into. So thank you for bringing that up. If there's any other questions, please add them to the chat. Chuck, did you have any points to make?
I did, and that was with respect to your comment. I think that that was a great pearl that should be one of the take-home points. Chai's talk was fantastic. Pre-contoured plates will put the bone where the CT, based on the design of the plate, puts it, which is not necessarily in a reduced position. And so Terry suggested maybe, especially in the delayed ones, reducing the carpus and pinning it. And that takes all the stress off of that little piece, and then you could put the piece where it belongs, and then fix it. Which one of those standard plates may not be adequate to hold that piece, and then you can choose whether to leave the pin in or to remove it once you've reduced it. Great points, both of you. Thank you.
You're welcome. Okay, thanks, Chai. That's wonderful.
Thank you.
So I'm going to pass the podium on to Dr. Ann Willett from Miami, who's going to talk to us about the limitations of volar plating of distal radius fractures. So Ann, are you there?
I am.
Great.
So let's see, we've got so you have everything, correct? You have the slides up?
Yes, we do. It's perfect.
All right, here we go. And at the end of this session, you're going to be able to recognize some of the alternatives to volar locking plates, analyze fracture patterns, and define the direction of the reduction and stabilization. And at the final, I have one of my own slides that I was not happy with that case, and where I missed some of the things that normally I'm able to do. So it'll be a great lesson in and all the aspects of this.
You
So,
want to hit I'm sorry to interrupt. Would you mind hitting resume slideshows? See that up at the top? I think that'll go take us to show mode.
okay, let's see.
It's a little box right above 32-year-old male.
Screen sharing, hold on. So did that do it for you?
There you go. Thanks so much.
Okay. So alternatives to volar locking plates. One size does not fit all. And analyze fracture patterns, define the direction of the reduction and stabilization. And that's not always easy. So in these cases, Terry was kind enough to share with me, as I've been in private practice and seeing a lot less of the crazy, wacky trauma from Jackson. But here's a fracture pattern with the dorsal fragment, and now the carpus is beginning to sublux dorsally, and you can see the fragment on the CT there, and then the lunate is going up with it, and then you see it move over onto the radial side with the scaphoid, so that you've got also a radial styloid portion that's going up, and so these actually can get pretty complicated, but they're going dorsal, so it's very hard to capture them from the volar plate. So the approach is dorsally. It would be a first and second dorsal compartment. You never want to go through the fourth, because you do not want to interfere with the extensor retinaculum to the fourth dorsal compartment and then get bow stringing of your extensor digitorum communis tendons. And then you get the EPL out of the way, and that also decompresses it, because that's the other problem, is sometimes EPL ruptures just in a distal radius fracture, whether you open it or not. And then here you are opening up and the EPL being pulled to the side, and then the fracture being exposed. And so by doing this through the second and fourth, now you've reflected the fourth up, but again, you have not disrupted the extensor retinaculum nor the compartment. And now you can put plates along the dorsum and where they fit the best in these. And then for the ulnar side, again, you're going to come between the fourth and the EDQ, and this is actually, you can just slide right in there and then pin it and hold things in place, and then put whatever plate fits that column and buttressing it. And with us, one of the things that we learned is bone grafting, particularly on some of these comminuted fractures, and dorsally, you get quite a bit of comminution. And so making sure that you bone graft across here also helps stabilize that plate and the fracture, so that you're not totally relying on your plate to be the only buttress. The bone is also giving it some stability. And so we will not use putty in this situation, but corticocancellous chips, either allograft or autograft. Here, this is fragment specific for radial styloid fragment and the dorsal ulnar fragment. And again, trying to plate 70, 90 degrees apart, because you're trying to get compression across all of this, but you still have to be careful about getting screws into the distal radial ulnar joint. So, and that can always be difficult, because as you can see, when you look at this, that screw is going to look like it's below the bone, because you're going to be looking on the x-ray here, but in fact, it may still be protruding into the joint. So you're going to need to rotate your x-ray as you're doing this. And so there are immediate post-ops. You see good reduction. Now the carpus is back in line. And so if there's severe dorsal impaction with dorsal carpal subluxation, you can't always reduce this, so disimpact it from the dorsal joint, but you can also go from volar as well, and so don't be afraid to go both sides. And there was a time where we really saw so many comminuted things that required us to go dorsal and volar. So don't be afraid to start one direction and then shift gears and go another. So here's a young man, 43-year-old, motorcycle accident, bilateral distal radiuses, treated with a volar approach, ORIF for both, followed up and complaining of pain and deformity on the right side. And so, when you look at this, you've got things in pretty good shape, but there goes that ulnar lunate facet. And there's part of the problem, and you get all this sinking of that. Now the lunate's banging in to the distal radius. And then here's the dorsal fragment as well. So the lunate is also subluxating with that. So remove the volar plate, reapplication of smaller radial sided plate to capture the scaphoid fragment, a separate dorsal exposure for the lunate facet with a buttress plate, and then putting it back into place. But you can still see that that lunate still does a little bit of a shift. So many times, even when you get this fragment back, it doesn't always get everything reduced. And exactly, what all that is in terms of ligament instability, et cetera, very difficult because it is volar dorsal. It is not just a one-sided affair. So here's my I wish I had. This is an elderly woman who is becoming less active, but still teaching. And she had had a previous fracture on the opposite wrist, treated by another surgeon in town, came to me. I had to do an osteotomy. And then so we knew we were going to go fix this. But I also knew she had soft bone. So again, I bone grafted, put the volar plate, and I think I'm pretty good on this lunate facet. And one of the things that I do intraoperatively is that I move them back and forth and really put a lot of pressure across this just to get it to fail in the operating room. Because if it's going to fail, I want it to fail there. And well, okay, here she is post-operatively 3 months later, and this whole piece has fallen back. Now, the good news is her radius is still out to length. The surface here, you can see the lunate is still articulating here as well as the scaphoid. And she actually has pretty good pronation supination, enough for her to function at 60-60. And she has dorsiflexion, volar flexion of 35, and she's not hurting. So this now, you start to go into the framework of elderly female. I at least got things back out to length well enough, and she's not hurting. And so at that point, we decided not to go any further. We're just going to watch her. But if we have to, we'll go back, take out the plate, and maybe push that up. But I don't think so. I don't think we will have to because she's not hurting. So are volar locking plates the ultimate answer? No, never. There's always other options. The other aspects of plates, both dorsal and volar, as you can get tendon ruptures. Although when you're looking at the list of papers out there, the volar actually has more tendon ruptures than dorsal. And that's both dorsal and volar tendon ruptures. Stiffness is about the same. And the nice thing about the dorsal plates is when you're unable to control those dorsal rim fractures or fracture subluxation from a volar approach, don't be afraid to flip and go dorsal. So not all distal radius fractures can be managed with a volar plate. Carefully analyze, recognize the dorsal volar impaction subluxation, and direct dorsal reduction and stabilization. Thank you.
That was great, Anne. Any Q&A about this point? While the questions are coming in, I'm going to just take this opportunity to ask Jesse to answer live one of the questions that came in just as your talk was starting, Anne, if that's okay. Jesse, are you there?
Yes, I'm here.
So one of the participants, you already answered this, but it'd be great if you did it live. Some pearls for passing that suture wire that Chai described, that suture wire through the volar capsule to capture the volar lunate facet.
Yes, if you take a large bore needle, like an 18, and bend it slightly and pass it through the stout volar radiocarpal ligaments on the ulnar side of the wrist, and pass your wire through that as a wire passer. And then if you have, as Dr. Mudgall showed, a plate or screws, then you can wrap it around the head of the screw once you've got the lunate back in position. If not, if you're using it isolated, then make drill holes through the metaphysis of the distal radius and pass like a suture passer, or use the same wire, a needle holder, and pass it through a drill holes that you made in the radius. It actually works very well, and we used it quite a bit before we had the volar locking stout implants or the hook plates, etc. So when we were using K-wires or X-fix, the volar lunate facet as an isolated fracture would be well supported with the wire.
Great. Yeah, it's a great trick, and I've used it quite a few times. I know Tom Fisher's a big fan of it as well, and he showed me a couple of times where he's used it for cases. So thanks for sharing that with us, Jess. There was another
point.
Yeah, go ahead.
So exactly as Dr. Jay said, with the needle as a suture passer, you can do that. The other thing is you can just bend it into a large hook-like bend in the wire itself, and that gives it a little more stoutness, so it can be passed easily. But the one thing I probably did not emphasize enough was that the wire should be right at the edge of the fragment, so it's going through the Sharpie's fibers, and so that when you tighten it, the fragment falls back into its bed. So that's number one. And number two is that screw looks a little prominent, and I know that. The reason the screw is not cinched down fully is because I had already managed to snap one wire in the act of cinching the screw down fully. So that's one of the concerns you have. So I left a little prominent, knowing fully well that because of the curvature of the radius, the screw would not be more prominent than the volar rim of the radius anyway.
Kai, one more point, if I might.
Yes.
When you're tightening these small fragments, whether in the radius or in the hand, you have to be careful to make it too tight.
Yes.
Because if you make it too tight, you will actually over rotate.
Yes.
Lunate facet. So keep that
yes.
in mind. Hastings asked the question, can you tighten it too much?
Yes, and you can do the same with suture anchors also.
Yeah, absolutely.
Yeah. And you suddenly realize that you tightened the suture anchor so much that you don't have any wrist extension. So
Yeah,
you have to be careful with that also.
Hi, Jesse, Terry, and panel. One of the questions from the attendee is there any advantage to using suture instead of wire?
Shall I take that?
sure.
Certainly.
So if you wanted to use suture, I totally understand. Like I said, I tried to include the hardware in an attempt to address resource-rich as well as resource-poor environments. However, I may have not included suture. And yes, you can use suture. I have used suture, and I usually use non-absorbable polyfilament because its knotting characteristics are better. And so I use Ethibond just to give you a name. You have to be careful because when you tighten it, you need to step on it with a snap or with a needle driver, and you can fray it. So you just have to be careful. I don't use monofilament for it, but yes, you can use. And if I were to use it, I use a 0 or a number 2 Ethibond.
Very good. Very good. Great. Anne, I'm going to ask you a question. If you were faced with one of those fractures where you had to approach it dorsally, do you have any specific implant that you would prefer to use, or would you just take any kind of old small plate and contour to make it fit?
Right. So I like the AO set because it gives me a couple of choices of L, T, or straight. And again, those fracture fragments and the strength of the bone is part of the problem. And so sometimes you'll pick a plate that is more of a buttress plate. In other words, that T or the L you can use to kind of push it. So I don't know, I'm a bit old school. I like to stabilize the plate proximally in good bone. And then I like to reduce the fracture up to the plate and use cortical screws, not locking screws, to suck the fracture up to the plate. And so that's either direction. So I'm torquing that bone in the direction I want it to go by using the cortical screws. And I'm not even sure that I can totally explain it, but you can just watch that fracture dial in to the plate. and now be aligned. But you have to push it and then you have to pull it in. And so for me, I really like cortical screws or lag type screw fixation. And then I will use the locking to lock the plate against what I have created in terms of sucking that fracture to the plate and getting the reduction that I want. One of the things that I really wish I had done in the, I wish I had thought about going dorsally was, you noticed I had to torque her radial styloid into alignment, which meant that plate, the volar plate, was also in a funny torqued position, but that's what it required to get that fracture to reduce out. Now I kept the main portion of it reduced, but it would not solve that lunate facet. And even though it looked solid at the time when we left the OR, obviously it did not stay so. And even putting an extra screw into that fragment would have been a problem because she had such weak bone. And what I was really worried about was splitting it apart, trying to catch it with a volar screw. So those are my my tips. I don't have any other special plates or anything like that. It doesn't matter which kind of locking, cannulated screw that you use. I've used everything from Integra to the Synthes locking screws, headless screws. It really doesn't matter, whatever you're comfortable with if you're going to do a lone screw like that.
Great, thank you. One of our attendees on the chat, the Q&A, asked the question, which I'm just going to lead into. It's very appropriate to what we're talking about, which is utilizing even smaller plates, like the 2.0 and 1.5 plates. Sometimes those little fragments are so small that it doesn't really matter. You don't really even need a big 2.7 or 2.4. You can just use a 2.0 plate or even one of those little cage plates just to buttress that fragment down. So that's another alternative at times.
Right. Or anchors. Again, anchors for those smaller fragments like that. I've used anchors to suck those fragments back down to the bone, a peak anchor or something like that. And that's worked well in order to stabilize it, because you're also stabilizing the ligament that is attached to that little fragment.
Absolutely. Chai, you had a point?
Yeah, it just occurred to me that the case that Anne showed where the lunate facet displaced highlights the points that the three of us made together. So Jeff alerted us to the elderly wanting shared decision making. That was number one. I pointed out the vagaries and the late diagnosis of the lunate facet, and Anne showed that you could leave them alone and still have good motion. And that precise point was highlighted by Dr. Jupiter in his paper in 2004, where he compared patients who had a revision internal fixation of a displaced lunate facet fragment after internal fixation. And I believe he had 4 or 5 patients who underwent internal fixation and 2 or 3 who did not. And it was very interesting. The conclusion of the paper was they did just the same. So I think that that one case literally encapsulated all our 3 talks.
Very, very, very good.
Can I make a comment, Terry?
Of course, Mr. Chairman. Yes, please go ahead.
Thank you very much. I think we've learned so much from Tom Fisher and Jesse and Hill and you and Doug. We've also learned a lot from our trauma colleagues who take care of tibial plateau fractures, and that is, they used to use large fragment plates to treat them. And the fractures inevitably would collapse until they hit the screws, the traversing screws, which couldn't be that close to the articular surface. And so it calls into question, what is the purpose of the fixation? So is the purpose to capture the fragment or buttress something? What is the mode that it is being used in? And Anne mentioned bone grafting, and so just like with our experience with tibial plateau fractures, if you use bone graft and the screws are at a distance away from the articular surface, the fracture will settle until the subchondral plate hits the screws. And so your point about using small plates, locking plates in a buttress mode, they're not capturing fragments, they're just buttressing, is very important. In the setting, like Anne said, if you're in a situation where you have to use the bone graft to elevate an articular surface, you get the buttress of the metal close to the subchondral plate, that maybe a bridge plate or something to protect it while it heals may be appropriate.
May I make 2 points?
Dr. Jupiter, it's wonderful. Go for it.
One is the concern about dorsal plates causing tendon irritation has been real, but I think you have to realize that the plates that are available now on the market are machine polished. They're much lower profile, smoother, and the screws are recessed in the holes. So the problems we used to get were prominence of the screws, prominence of the sharp edges of the plates, and that's not necessarily the case. And the second point is regarding the size of plates. Realize that there are other options, so-called pin plates and other smaller devices that absolutely changed the concept of size. If you can support these fragments with basically staples or little wires, then certainly suggests we don't need bulk in this area.
Great points, Jesse. Thank you.
Barry, I don't want to eat into your talk at all, but Hill brought up a good point about bone grafting. It is and I agree wholeheartedly, it's a good reduction device. So just an added point.
Yeah, and then it comes up the point of where do you get it from? And Anne mentioned using allograft off the shelf, little niblets of bone, or you can take it, sometimes you can take it from more proximal in the metaphysis of the distal radius, like borrow from Peter to pay Paul, go from a good zone of the radius to help. Sometimes you don't have that option, so you can go to the olecranon.
Exactly.
And get some bone from there. Those are sort of the areas that I like to use because 99% of these cases are done under regional, so you don't have the option of going to their iliac crest.
And one of the reasons why we went to allograft bone, part of it was we had the University of Miami tissue bank, so we had that easily available. And so we started using this in the late 80s. But the other reason was that, we've been trained by Burkhalter and crew to take iliac crest. But in these little ladies, you can take your finger and just go and smash their iliac crest so that you don't get any stability. That's like putting a bone putty. And so that's one of the reasons we went to allograft bone and started to use it, because we had a much better structure to support with and to reduce with.
Okay, I'm going to move on. Thank you, everybody, so far. So the last part of the presentation is to talk about what to do if the fragments are just too small for standard fixation. And so we'll go back to our 63-year-old patient with inflammatory arthritis who's on steroids, methotrexate, and has this severe cardiomyopathy. So her initial reduction, as you may recall from the beginning, looked pretty darn good. And I must admit, I thought that that would be just fine. But I got a call from my colleague who saw her in follow-up at 6 weeks and said, well, we took the cast off and you better come and look at this. I think we need some help. And the patient was very unhappy. She noted significant deformity to her wrist. She said she has quite a lot of pain and she's a pretty stoic individual, doesn't complain much. And her wrist was really crooked. And these are what the x-rays look like. So it's a very interesting set of x-rays. I mean, to go from, let's go back to this, from this to this in 6 weeks is a pretty unusual situation. And so we tried to image it more because just to sort out what we had left to work with. And this was a CT scan. We can see on the lateral, we still have a bit of a volar LUNATE FACET piece to work with. The dorsal cortex is pretty much, the dorsal piece of the joint is kind of dissolved away. And on the PA, you can see the split, which was a very minimal interarticular split, has diastased. And it's just a kind of a thin wafer of bone that we're left to work with. So she was pretty unhappy and she could be convinced, or, it's a shared decision making. And we kind of made a deal that I would be willing to do the surgery for her and she'd be willing to have it if it could be done purely under regional anesthetic. So we said, sure, we'll try something under regional, and odds are it'll work. Our anesthesiologists are pretty good with that these days. So we took it to the OR, and we ended up doing this. So we ended up putting a little volar plate on. Well, it's not little, but it's the juxta-articular volar plate. I didn't put in any distal fixation at the beginning. And then I just reduced that whole dorsal subluxation of the carpus and pulled her out to length, utilizing a minimally inserted, that is 2 little incisions, distal and then proximal, and utilizing a Hanno plate, as you see here. And that allowed us to reduce those little tiny fragments and basically put the hand at the end of the forearm where it belongs, as opposed to dorsally out the back somewhere. And then I put in a couple of screws just for good measure. Probably didn't need to put in those screws, but just to hold it a little bit more. So that's what I ended up doing. And then so I saw this delightful lady back for follow-up, and I saw her at about 8 weeks, and she was very happy with the result. And she said, my fingers are moving perfectly. I have full forearm rotation. Look at me, I'm all happy. And I have no pain. So she's very happy. So I said, okay, we'll see you back in about 3 or 4 months, and we'll schedule you for removal of the plate. And she looked at me like I was from Mars. And she says, I'm not having this plate out. My wrist is perfect. Why would I want it out? And so I never saw her until her husband came in with a broken leg about 3 years later. And I said, how's the wrist? Do you want the plate out? And she said, nope, I'm happy with the way it is. So here's a picture of one of our co-faculty who will be in sessions later on during the course. But Doug Hannell came up with the idea of an internal external fixator for management of these very complex distal radius fractures. And this was back in the time when I was first starting in my practice in the early 1990s, when everything was treated with an external fixator. And the external fixators, as we all know, had their own set of problems with them. And one of them was you were unable to restore the palmar tilt. And very often there was always some residual dorsal subluxation of the wrist relative to the forearm. And the patients didn't like these frames on their wrists. They kind of came into the clinic with their hand out here somewhere and said, ugh, can't you get this thing off? And so Doug came up with the idea of an internal external fixator. And the concept is small incision proximally. Usually you enter the second compartment here on the proximal portion, and you slide the plate up the second compartment. If you need to do something at the joint level, you can open it up at the joint level and reduce a few of the dorsal fragments if need be. I must admit that I rarely open them dorsally, so I don't often use this middle incision. And then onto the second or the third metacarpal. I tend to put it on the third metacarpal mostly. Again, this is just done percutaneously, and these plates are very narrow and will slide up quite easily. And this is a case from one of Doug's papers from the first publication. It shows the typical patient that might benefit from this, a 75-year-old, multiple comorbidities, poor bone quality, and a multi-fragmentary fracture that back in the 90s, you wouldn't be able to manage this with a plate and screws. There were no devices available. One could argue that maybe a metadiaphyseal plate would work for this today, but even with that, the chance of failure is quite high given the amount of fracture fragmentation or comminution that you see. So this was managed with a long plate. This is not a specific so-called Hanno plate. It's just a standard long 3-5 plate. But I think you can all appreciate how using the dorsal plate pushes the wrist, the lunate and the capitate back in line with the forearm. It restores your palmar tilt and your palmar axis, and it really works beautifully at restoring length. And it's a great way for holding the wrist out to length till it heals. And as it was published back in the 1990s with this, plate should remain on for about 4 months to make sure that the bone fully consolidates. And quite surprisingly, the restoration of movement once the plate comes off is remarkably good. And these patients get back really good movement. So this is a really good tool to have in your toolbox. So this is a form of a bridge plate. So it's an additional device in our toolbox for the management of these complex multifragmentary distal radius fractures. It's most useful in my experience where there's multiple tiny joint bone fragments, poor bone quality that makes it hard to get fixation. And this situation where you've got the joint sublux, particularly dorsally. So one of the cases that Chai showed with a radial carpal dislocation, it's a really good tool to use to help to hold that in place. It allows the volar ligaments to heal. It's very easy to insert. After you put in 1 or 2, you can put them in just a few minutes. And the recommendation is generally take them out at 4 months, unless you have a patient like mine who just disappears and never wants it out. And the results have really stood the test of time. And I think it's just now, 20, 30 years after Doug first described this technique, that we're starting to use it more frequently. So thank you, Doug, for this. So are there any, that's all we wanted to do formally. So we'll open it up for additional Q&A. And then I've got a couple of slides to finish off with at the end.
I think our historian, our resident historian, Tom Fisher, would like to tell us about the history of the bridge plate. Tom, are you there?
Yeah, I just I love Doug Handel to death, but it was really Jim Beckton of Savannah, Georgia, who first coined this idea of a bridging plate, and he was an early AO hand course guy, and then Singer and Burke in Milwaukee were the ones I think that taught it to Doug, and then Doug kind of perfected the concept and made it kind of reproducible for all of us to use it, and gave us the confidence too to use it because he did it so effectively, and really gave us a reproducible and refined indications for using a dorsal spanning plate. So that's kind of how it got in there.
Tom, exactly. The histories are a bit like that. Ed Burke and Rick Singer are in Detroit, and they were the ones that I think discussed it with Beckton. So I learned it at the AO meeting, or at the Hand Society meeting that was in Seattle in, I believe, '99 or something like that. And then we continue to use it. It is a technique that we use here in Seattle, and at Harborview, maybe 1 in 100 times, 100 fractures. And it has really been a go-to for salvaging failed fixation with all the things. And the one thing that I've learned now, that I will go and I will do if I've got a really comminuted unstable fracture, I'll fix the volar ulnar corner first and put a little small plate that would never hold up by itself, and then go dorsally and put on a spanning plate to complete the fixation. And the magic time to healing is when the fractures look healed. And so that's usually somewhere around 4 months, but I've kept plates in place for up to a year, watching fractures heal very slowly in some elderly patients or otherwise compromised patients who healed slowly because they were on chemotherapy, very much like the case that was presented here.
So Doug, one thing that I comment on is how quickly they get back their movement after the plate's been removed. We're always taught, motion is life, life is motion. And if you put a plate right across a joint, it's going to ankylose. But has that been your experience as well, that they get their motion back quite readily without a whole lot of fuss?
Yeah, Alex Lauder, who's on faculty at Colorado, looked at all of our spanning plates here when he was a resident at the University of Washington, and it is really truly remarkable. And I agree. I originally, my first 3 cases of using this were in patients that I thought were going to need wrist fusions, but they didn't have any metaphyseal bone that was in continuity. So so I left the plates in place until the metaphyseal fractures, metadiaphyseal fractures healed. Well, he took the plate off and they had this great motion. And so we said, well, let's just see what they do with their great motion. And they just continued to have it. And so I'm as surprised as anyone else. And so we reported that purposely, just to demonstrate that that's indeed true. And you can expect that. Patients get somewhere between 70 to 80% of their wrist motion back after prolonged immobilization with this device.
Yeah, Doug and Terry, I think it's interesting after distal radius fractures, you can take the worst fracture and most people will get 60 up and 60 down.
Yeah.
A lot of that comes from the midcarpal joint. So it's interesting to fluoro patients after this and see how much of the retained motion is really midcarpal versus radiocarpal. But I agree, that's one of the reasons why they indeed do so well.
Yeah, again, and we've done that. And looking at the great majority of the motion is midcarpal, but there's still a fair amount of radiocarpal motion that is there. And where do they lose their motion? They lose their motion at the radiocarpal joint, not the midcarpal joint.
Can I make a point about that? Because when we looked at the various discussions tonight, and even with deformity, we've seen patients with an adequate amount of motion, but function follows form. And I think that the dorsal volar range of motion, as Hill pointed out, can be to a large degree mid-carpal, but the forearm rotation, the distal radial ulnar joint, is very critical, especially to elderly patients who are on their desktop and working on, if they're independent, single, widower, widow, cooking and doing performance tasks. So I would just like to summarize by saying what Terry Axelrod pointed out of shared decision-making. It's incumbent to us to find out what functional needs our patients when they're presenting with these fractures, because many patients, as they pointed out in the first talk by Jeff Lawton, are functional. They're doing athletic activities. They're doing rotational, such as tennis and other things. And those patients shouldn't be looked at by chronology, but by functional aspects. And I think that's an important message that I learned. And we looked at a large series of patients early on and found that it was very important for some patients to regain their functional status.
That's
a great point. Can we, I promised that we would have a mini debate at each of these. So a 30-second debate, Terry, second versus third metacarpal. Doug, Terry's a third metacarpal. Doug is a second metacarpal for bridge plate. Why?
I'll go first.
Okay, you go first.
So if you have the second compartment retinaculum in place, and you place that plate along that, leaving the retinaculum in place, you will restore length, tilt, and inclination just by that. And we've demonstrated that in the lab.
All right.
Yeah.
Okay, my answer, I like the third. I mean, I agree with Doug. It's a little easier to insert the plate if you just stay in the second, but as long as you open it up and release adequately distally, you can get it onto the third very easily. The way I like it is, the reason why I like it is it puts the hand in a more natural position. So when you fuse a wrist and you use a wrist fusion plate, you generally put it on the third metacarpal because it puts the hand perfectly aligned with your forearm. It's not off this way, it's straight. And from a functional perspective, that's a much more useful position for the hand to be in relative to your forearm. And I always worry about these patients not coming back or perhaps getting really stiff afterwards. And I'd really rather having them not coming back with a straight hand or a stiff hand that's more in line with the forearm. So that's why I'm a third metacarpal person. But honestly, if the third metacarpal is broken or something, then I'm going to put it on the second. I don't have a problem with either, but I prefer the third for that reason.
So Chuck, I'm going to take a third lane.
Yes.
I normally go
fourth
with the
metacarpal?
No, not the fourth, not that third lane. So I normally do put it on the second for the reasons that Doug said, but when the patient has a displaced dorsal ulnar corner fracture, going to the third, it allows you to anatomically reduce it and buttress those small little fragments.
Yeah, there's one other place that I think that the third is better than the second, and that's in those very distal fracture dislocations. I think it does a better job of holding things in place.
Yeah, I think all of us who've used that have patients who've decided not to have it removed, and so it's a great idea to put it on properly from the beginning in those elderly patients, and some of them are satisfied with just leaving the plate in place.
Yep.
Just to circle back to Jesse and Chai for 1 second, Jesse made a great comment about forearm rotation, and Chai was talking about the volar ulnar corner. Those fracture fragments involve the distal radial ulnar joint, and they can lose forearm rotation. Those, if they're not reduced properly, they can lose forearm rotation, and particularly supination they'll lose.
The thing
I'd
that
like to make a comment about articular fixation when you have these spanning plates, whether it's a spanning external fixator or a spanning internal fixator. I think reapproximation of the articular surface and restoring the articular surface with K-wires, small pins, screws, tension bands, whatever you want, little tiny plates, that is the articular restoration. And then the neutralization device used to be the external fixator. Now we've got this lovely spanning plate, but really get that articular surface, especially the distal radial ulnar joint and the lunate facet, back in good stead, and then span it after that.
I agree with that, and because although it's a great plate, I'm seeing more and more young surgeons using this as a get out of jail free card.
Yes.
And they'll just slap this on, and without any regard for reduction of the articular fragments. So follow the principles of the external fixator era, where you reduce the fragments and then use it as a neutralizing plate only.
Well said, Dr. Gupta. Perfect. So the time is getting late. It's 8:33. So I'm just going to finish off with my last few slides, if that's okay. I want to thank everybody for the amazing discussion tonight. So, so the take-home message from this session are really getting back to those 4 questions that we had at the beginning. So we have this decision-making around what patient, what fracture to operate on can be difficult at times. It's a shared decision. Patient expectations, level of expected function, that is patient expectations, are critically part of this decision-making process. And I think, like as Jeff talked about so well in his talk, if the patient is involved in the decision-making process, I think it goes a long way. And also the fact that if you lay out what they can expect with closed treatment, and that there are alternatives, even partway through the program, or after healing. You can often do something to salvage it. And then the next talk, which Anne helped us with, was about distal radius fractures. Not all of them can be approached from the volar side. And when you do have, and I think the case that I lent to Anne, where there was already a volar plate on the fracture, really illustrated that point. The volar cortex was completely intact. There was no way to access that dorsal fragment. And I think the surgeon who did the original surgery did not appreciate that a dorsal impacted fracture subluxation or fracture dislocation is a different animal, and that needs to be approached from the back. The volar lunate facet fragment is critical to carpal stability, and Chai showed us 5 fantastic cases of how to manage that problem. The basic rule is where that fragment goes, the lunate goes, so careful support during ORIF of this fragment has to be the goal of surgery when you're tackling it. And then finally, we've had great discussion at the end here about when you're faced with a very complex fracture, there are alternate methods of fixation, including a dorsal bridge plate or external fixators, although we don't use the X-fixes very much anymore. But as Amit Gupta just chimed in at the very end with, don't forget the basic principles. It isn't a get out of jail free card. You can't slap them on everyone. You want to adhere to the principles, reduce the fracture, and if you just need something to neutralize the compression forces, reduce the tendency to dislocate, that can be a good device to use as well. So I think that takes us to our end. These are the remaining sessions within the Advanced Risk Summit that our chairs, Marco and Chuck, have put together for us. So we finished off on January the 14th on distal radius fractures, and the next one, I think Jesse's doing this one, sharing this one on distal radius malunions. So that's 2 weeks from now. Then February the 4th, carpal instability, perilunate, scapholunate. There's It's not every 2 weeks. There's the odd week where we have to skip. So February 11th is on scaphoid fractures. So this is just 1 week apart. And then the 25th on scaphoid non-unions. Then we get into that really well-defined aspect of the distal radial ulnar joint, that big black box that we just don't understand, or at least I don't understand. Wrist arthritis, wrist arthroplasty, webinar. I think Amit, you're involved in that one. Arthroscopy, and then the take-home pearls at the very end. So that's it. This will be available on the AO North America YouTube channel, and there'll be a link to this through Zoom 24 hours over at the end after everybody's signed off. So, Hill, did you have a question? I see your hand up there.
No.
Okay, that's from before.
I want to give all of you guys a hand. There's a lot of work, and I think it was a great balance of didactic and getting people involved with questions and answers.
Thank you very much. It was a lot of fun. We had great faculty, Chai, Anne, Jeff, thanks for your help. And really, it's great that all the other guys logged on as well and gave us their 2 cents worth. It really helps to make this like a live event, because for those of you that are participants that haven't had the chance to go to an advanced AO hand or wrist course, the people that have been talking tonight, we do these courses when we're allowed to, pre-pandemic and hopefully again post-pandemic. We have a lot of this kind of interaction with each other as panelists, and just people stand up in the audience or at the back of the room and shout out their objections or their suggestions. And this kind of back and forth works to really enrich our own education, and hopefully for those of you that are listening to us banter. So thank you very much for your time, and appreciate you logging on tonight.